Hopefully, she slides and be triggered to say the right things. I wanted to first thank John Birch for his final comment. Microphone. Got it. Or his final question and comment. Do I need to do anything?
No, I think you're good.
Okay. Because he set it up pretty perfectly for what we do. So we're excited to be invited here. Livongo is, I'll tell you a little bit about what Livongo is, but we're excited to be joining this esteemed group of colleagues in this space. Let's see, do I do the slides? No. Slides. Oh, these are the three things I'd like to talk about today. What is Livongo? What are the challenges that we have or that we face with our business of remote chronic condition management? Talk a little bit about our real-world evidence partnerships and a few thoughts on the use of digital tools for clinical research and medical product development, though I know we have many greater experts in the room on that. So what is Livongo? I don't probably need to tell this group of folks what the impact of the health and cost impact of chronic conditions are in the United States. 1 in 3 people have a chronic condition. Many of those have more than one chronic condition. 75% of the U.S. healthcare dollars are spent on managing chronic conditions, and we're talking enormous sums of money. For many Americans living with chronic conditions, there's confusion, complexity, and cost of the healthcare system is overwhelming, and that results in people ignoring their health conditions. We call this noisy healthcare. Our solution to this noisy healthcare is what we call applied health signals, and it incorporates some of the problems with clinical trials, actually, that we were just hearing a lot about. The 4 components of this applied health signals are aggregate, where we aggregate data, interpret, where we use multiple tools, the medical literature, clinical advice, clinical opinion, to interpret these long, big streams of data. We apply the data, and then we iterate that process again and again till we get, hopefully, the outcomes that we're looking for. Livongo is a patient-centered or consumer-centered digital health business that was first focused on diabetes. We started with a cellular-enabled connected glucose meter in 2015, and that captures data in people through a cellular connection living with the disease, and they're 99.9% of the time when they're not in the healthcare provider's office. In 2018, this year, we expanded our program to include also diabetes prevention with a cellular-enabled scale to capture data. And then next year, we're currently in beta testing for our hypertension product, and so next year we'll launch a connected health blood pressure cuff to help manage hypertension at home. So when we aggregate data from these devices, that's not all the data that we need. As we were talking earlier in the earlier session, we need data about people's actions, people's choices, people's food intake, people's medication intake, their activity, and that's what we do. We aggregate all of these data sources. Also, we get information from medical claims, pharmacy claims, all towards the goal of helping people lead healthier lives by spending less time worrying about it. The hard part, I'm going to go back to the hard part about what we do is really the interpret part. The interpret part, as we all know, we have tons and tons of data that we're collecting now, and being able to come up with meaningful signals from these health data streams is really the secret sauce or the special impact that we have, or we believe we have at Livongo. We have a large team of data scientists, behavioral health specialists, certified diabetes educators, physicians, who all work together to use these data and structure these data in a way that's clinically meaningful and present it back to the patient in, again, a meaningful way. What is meaningful is a constant debate internally. But thankfully, we have some consumer technologies from a lot of our big data companies that operate in other industries that allow us to use sort of A/B testing and other tools that are not quite the rigorous clinical trial, but allow us to iterate more quickly on some of the interventions that we use. The goal, of course, is to apply. So that's AI-A, we're at A, to apply the insights from these large data sets to various patient populations. And we don't specify or take out specific people that we target. Rather, we work to meet each individual where they are with their evolving chronic condition. So the people with chronic conditions are very diverse, their needs evolve over time, and our mission is to meet them there in their lives, to spend as little time as possible thinking about their condition. The other important thing is that the patient, or the member in this case, doesn't pay for our system. So we have over 400 clients and organizations that provide Livongo for their employees or their members. So they could be a self-insured employer, they could be a health plan, provider system, and even clinical trials organizations. So what are the challenges of remote chronic condition management? Well, a lot of them, again, were brought up earlier. I'm going to focus on 3. One of the big ones, when we talk about weight data, that's a data source that we use, is thinking about, are we observing the right person? Are we observing the person that we think we're supposed to be observing? In our system, there isn't a lot of incentive for someone to utilize the materials or the devices that maybe their housemate has, whether it's a glucose monitor or a scale, because one is provided to each person that's part of the program without any cost to them. All the strips, all the test strips, all the materials are provided. But here's a case where we have a scale where there's multiple people stepping on this scale, right? And how do we decide, or how do we know that which one of these people are our participants? Well, there's some very simple things that we have, right? Their self-reported weight at registration that can help us. We can ping them through our device or our mobile app to say, hey, when you step on the scale next time, tap here so that we know that that's you, and we can match your weight with the specific, make sure that it's you. But you can see, and my favorite thing to point out about this is that we also have, this very smart data science team that can help us parse out through various statistical techniques and what is likely to be a true value or not, to get to a more streamlined data source. In this case, I love to note that we see a decreasing trend, right? Of course, that's a good thing. But not only in our participant, we see a decreasing trend in the other household member, right, who wasn't one of our participants. So that's one of my favorite things to point out about what it's like to be taking care of people in their own home. There's some good side effects or benefits of that. Another problem we face is, how do we create these meaningful health signals, right? So the glucose meter that we provide is a fingerstick glucose meter, kind of on the old-fashioned side, but it's actually pretty smart. It has a two-way connection, and it gives information back immediately right after the glucose is checked to talk about not only the glucose, what does that glucose value mean for that individual, but what were the person's trends over the last few days to weeks. What would be the recommendations based on those trends? So there's this real-time, perfect moment that we have interacting with this person in a two-way, meaningful two-way stream there. But one of the problems we have is that if you're working in the field of diabetes, you need to measure people's hemoglobin A1C. And in spite of all of my requests and emails and proposals, we don't have funding to measure hemoglobin A1C on all of our 110,000 participants, every 3 months. So we have to take these data, the stream of data that could potentially be more valuable than a lab-based, quarterly lab test, and figure out how to apply that to the literature and use the literature to talk about risk stratification, all the things we can do for people. So this is an example of how we've taken a stream of glucose data and been able to assess members at where they are at their home, understanding if they've checked their glucose frequently enough for us to have a reliable, feel like their estimated A1C or the value that we've estimated for them based on the literature is a reliable estimate. If someone is checked, for example, 10 times over the last 3 months, we don't have a good sense that that person has a reliable estimate. We have a very, this concept we've called observability, and it's our ability to sort of observe people in the at-home setting and their health status. And with this sort of data science technique that really uses the power calculation idea, like how many checks do we need to detect a difference, that kind of idea, we can increase our ability to observe our members from 25% initially, right, to 53% of our members. So these types of things are important for, and the problems that we sort of face when people are living in the real world. They're not following protocols that are on clinical trials that say, check your blood glucose 7 times on this one day and then 7 times on that one day. They're just living their regular lives. They have multiple different physicians who have recommended different things to them in terms of how frequently to check their glucoses. So these are the types of issues and one of the solutions that we've come up with. And then the third and final example we have is about offering chronic condition management is how do we best coordinate the care for members? So we currently do not serve as a provider. We do not write prescriptions for members, but we have all sorts of great algorithms that tell us when someone probably isn't on the right medication or they're not on the right dose of the medication, if they have very frequent hypoglycemia, for example, or they need to be started on insulin. There's no chance that the medications that we know that they're taking from their pharmacy records, there's no chance that they're going to get into a good health status, as we look at their blood glucose values. But that is a challenge, right? We don't want to replace the provider. We want to support providers. And so how we interact with providers has generally been through the member. So we make it easy and to empower the member or patient to understand what it is to talk to their provider about. We provide materials to them, health summary reports, that type of stuff. But engaging the provider has been a tricky one. We have other relationships, not just the doctors, but with pharmacies. So, for example, some of our clients have, we work with the pharmacy benefit managers, and when we're interacting either in sort of a digital way or in a one-to-one coaching way. So we have a group of about 50 coaches that also work with our members if the member is interested in that kind of coaching or if there's a need that we see identified by their glucose trends. And working those certified diabetes educators can have a hotline to the pharmacy or to the pharmacy benefit managers so that we can do a hot transfer when there's situations that can be helped by a pharmacy expert. And then finally, talk a little bit about our real-world evidence. I think living, because we have data coming in from people living with real-world chronic conditions, we have been approached and are working now with several pharmaceutical companies and academic institutions. I always wonder exactly what we're talking about when we talk about real-world evidence. I heard that debated also, and I just take the New England Journal of Medicine article here and help us to define it. And we believe it refers to information on healthcare that's derived from multiple sources outside the typical clinical research setting. So EHRs, which we have access to for some of our clients, claims and billing data, which we have access to for some of our members, product disease registries, which we have at Livongo, an ongoing registry for multiple chronic conditions, and then data gathered through personal devices and health applications. So we have all of these things. So we qualify, I think. And I'll give you sort of 4 examples of the projects that we do, and I think it's particularly unique because we get to cross all sorts of barriers with working with pharmaceutical and academic institutions, as well as a startup. The first project that we've done is looking at the financial impact of our program on on members who have used it for a year. But we're able to subsegment that by all of the different starting hemoglobin A1C values, and where is the impact the greatest, and where is the cost savings the greatest, and which groups of people. Other examples we have that haven't been announced are looking at the real-world patient outcomes for people with various levels of empowerment to take care of their disease or distress, as it were, as it relates to diabetes. Looking at the variability of glucose in people with type 2 diabetes on different medications. And then finally on looking backwards at could be recognized patterns in blood glucoses with specific algorithms. So I have very little say, and I see my red light flashing compared to many people in this group. But the remote collection of health device data, I have one just point to focus on, and that's what we've seen, which is a big impact of the Hawthorne effect. I think when people are being monitored, at least in the worlds of chronic conditions like diabetes, hypertension, when people know that they're being watched or they feel accountable to the whole system, we see a great impact in their health. And so as you start to move clinical trials into those settings, it's important to just think about how the actual monitoring might be impacting the outcomes. That's it.